Again, I apologize for this inconvenience. I'm really sorry about it. I had to restart the system. I think there was a lot of lag and it was not going properly. So I was telling you about some topics that I thought were relevant for this coming INICT. One is, you all know, obviously COVID is going to be the dominating topic because it's playing on everybody's minds. It's going to be in the synapses. It will be something that will definitely be asked. We're expecting minimum of at least 8 to 10 questions on COVID. Now, as far as the guidelines for pulmonary embolism is concerned, new guidelines have come, and based on that, we're expecting more questions. Now, this updated guidelines already I've covered last year itself in my eGurukul videos also, and in my live class also. And this is mainly what we're expecting is they might ask about pulmonary embolism in a pregnant female. What investigation would you prefer? You all know the radiation exposure is greater in the fetus with ventilation perfusion scan, whereas CT angiogram comparatively is safer for females. However, there's a flowchart that the European guidelines are recommending, and that is first you need to get a D-dimer done. You look at the compression ultrasound in the leg. If both are positive, the answer is pulmonary embolism, treat accordingly. However, if the investigations, the D-dimer is positive, but the ultrasound, the compression ultrasound of the lower limb is not showing DVT, then you have to do one of the two, either CT angio or pulmonary VQ, ventilation perfusion scan, for a pregnant female with pulmonary embolism. Of these two, fetal toxicity is supposed to be lesser. Lesser radiation is there for CT angio, whereas ventilation perfusion scan, the exposure of radiation to the breast tissue is lesser, so future risk of CA carcinoma will be lesser. So to repeat once again, if you have to talk about fetal exposure radiation are lesser, the answer is CT angiogram. That's the point to remember. Another important thing about pulmonary embolism is they'll ask you the midway. They'll not talk about obvious patient who's got very severe pulmonary embolism, nor about a patient who's very mild. You all know mild patient, anticoagulation is the answer. Very severe patient is going to be thrombolytics. The in-between scenario where the patient does not have hypotension, but the patient has got either a marker of cardiac damage like troponin, these markers are increased, or the patient has got imaging showing RV hypokinesia or right ventricular strain pattern, significant right ventricular abnormality. Those things are there based on imaging, or blood marker, that is troponin is increased. One of these two is positive, that patient also should go for thrombolytic therapy. So this is in between, that gray zone is where they'll target, so that you should be aware of. I've covered that nicely in my topic in eGurukul. Please do look at that. Pulmonary embolism, I think, is expected zone. Anticoagulant reversal, we already discussed at length in the class, and also I think it is an expected topic again this year. You all know for heparin it is protamine. For warfarin, when bleeding occurs, if it's mild bleeding, the answer is simply vitamin K. However, if severe bleeding occurs with warfarin, the patient should be on prothrombin complex concentrate, and this is known as 4-factor prothrombin complex concentrate. Okay, 4-PCC we say, that is for warfarin if you want to reverse the bleeding or something, reversal. Dabigatran, the answer is idarucizumab, and for patient who have got apiximab, rivaroxaban and all that, the answer is andaxanet alpha. Those are definitely very important because they have not come in the recent, and since they are very important, I am expecting it in the coming exams. You all know about bedaquiline. It is definitely now very important drug for multi-drug resistant tuberculosis. One new antibiotic has come called lifamulin, which has been coming here and there in many places, so chances are it might come in the exam. So this is basically approved for the treatment of pneumonia. Do look up this particular antibiotic. Then emtricitabine, tenofovir as pre-exposure prophylaxis. For HIV, they are modifying some pre-exposure prophylaxis as well as post-exposure prophylaxis. So dolutegravir has been added also in the post-exposure prophylaxis, is one of the important drugs. So do look at it, and this also I have covered nicely in my HIV videos. Bempedoic acid has been approved now for lipid lowering, but as you all know, the central drug for lipid lowering is basically statin. In those who cannot tolerate statin, this drug has been approved. Eculizumab is already, we all know, it's basically hitting complement factor 5. It was already known for use in certain conditions like, thrombotic thrombocytopenic purpura. So basically more than TTP, it is the HOS variant. The atypical HOS is where eculizumab has been approved. It's also approved in certain conditions. So basically where complement is hitting the RBC like paroxysmal nocturnal hemoglobinuria, eculizumab was used. In patients with atypical HOS, eculizumab has been used. That was something that was already there. Now they are saying eculizumab is also approved in the treatment for myasthenia and neuromyelitis optica. So this is a new thing that has come for eculizumab. It's an old drug. It is basically anti-complement, but it is also approved now in the management management of myasthenia and neuromyelitis optica. FDA approval for lasmiditan, as you all know, lasmiditans are basically 5-HT1F drugs. You all know that triptans are 5-HT1B and 5-HT1D agonists. Ditans are basically acting against 5-HT1F. So 1F is important over there. That's the receptor that they're acting on. So ditans have been approved also, and they are considered to be a good option in people with cardiovascular risk disease. Don't forget, triptans are not very safe in people who have got coronary artery disease because they are vasoconstrictors. In that case, ditans are supposed to be better. Okay, that's why lasmiditan is becoming important in people who have got ischemic heart disease. SGLT2 evergreen drug, and you all know that it is not only benefiting diabetes in multiple ways, it is supposed to be cardioprotective, it decreases cardiac failure, it is multiple benefits, cardiovascular benefits are there with SGLT2 inhibitor, but they're also showing it slows the progression of diabetic nephropathy. Okay, they're supposed to benefit by showing slowing of diabetic nephropathy. One important thing is in COVID, the good anti-diabetic drug is supposed to be DPP4 inhibitor. Okay, if you want to use an oral drug for COVID patients, remember the problem with metformin is metformin you can use. The point is, once the patient in diabetes become more severe, metformin causes lactic acidosis. So in a patient who's already got hypoxia, we don't want the lactate levels to increase and cause more problems. So this is one of the reasons why metformin is not a preferred drug in more severe COVID patients. In general, COVID favorable drug if you have to choose, the answer is DPP4 inhibitor. Second point is all COVID patients who are on oral hypoglycemic agents, who get admitted to hospital, meaning they will be on steroids. The moment they are admitted in hospital, they have to be on insulin. Okay, it doesn't matter what the glucose is, because invariably the moment you start steroids, the glucose will go up. So the recommendations are, in patients who are getting hospitalized, diabetic patients with COVID getting hospitalized, oral drugs will be stopped. The patient will be on insulin. Okay, so insulin bolus basal regimens are generally what is given. So one important, I'm sure you all know, sliding scale is never going to be your answer in your life. It's generally disapproved everywhere, neither for management of ketoacidosis, neither management for diabetes. Nowhere we are going to recommend sliding scale as treatment, the way how you use insulin. So basal bolus regimens are generally what is used. You can also use insulin infusion in very sick patients in the hospital, but definitely never sliding scale as the answer for COVID with diabetic patients in the hospital. I hope you understand that even if the patient is not diabetic, COVID patient, now the guidelines are very strong. Keep the glucose down and make sure that the patient does not have increased risk of developing fungal infections like Mucor. So I've covered these drugs, some more. This bremelanotide is basically a drug approved for hypoactive sexual desires disease in premenopausal women, and mepolizumab we already know it is basically for any eosinophilic problem, eosinophilic asthma, eosinophilic granulomatosis with polyangiitis, which is nothing but Church straws. Mepolizumab has been approved. So these are some of the things that they might ask in the exam that you should be aware of. Okay, so a lot of people are asking questions. I think they've all not been able to locate this link, or I don't know what the issue is, because I don't see many people asking questions here. Most specific test for HIV is Western blot or HIV. Obviously, the PCR should be the the most best test. You can't have anything better than the PCR, right? So some people are asking about advice for NEET and iniCT. My simple thing is for iniCT, there's very less time now. It's about, I think you have roughly around 10-12 days. So what you need to do in this is just notes. Remember, notes are going to be your backbone. So make sure you go through your notes thoroughly, because they are going to be the most important thing. So apart from notes, if you can do the last few year papers, particularly for the AIIMS papers, the PGI papers, these two at least are really relevant. And Enhanced and thing, if you can do, that's good. But at least AIIMS and PGI papers, if you can do last 3 years, that will be very beneficial. So this is as far as iniCT is concerned. For NEET exam, I think you have sufficient time now to do good revision. And if you can do 2 revisions, 2 proper revisions, then I think you are going to do quite well in the exam. The revisions that I'm talking about are mainly connected with the, the class notes. Now, I don't think new questions will be made. Whatever questions have been made already, they are going to be the ones that will be followed. The pattern will be what has already been done, that is 200 questions. We're expecting long questions that are going to be not subject specific. So that already we are aware, isn't it? We discussed that earlier. So that is what I think is likely going to be. I don't think they'll change the pattern or ask new questions or do any of those things now. So this is what will continue. So as far as the NEET is concerned, I think just focus on class notes. And apart from class notes, the same thing, discussing, that is COVID, the hot topics that are there, and anyway before NEET exam, whatever relevant and hot topics are there, we'll discuss again in one of these kind of videos. So those things will keep you updated, but that is the main thing. Any other updates are there in COVID, obviously we'll discuss those things also. But I don't think new questions will be formed now, because already the questions are there, they have already formed it. And my feeling is that the same paper that has been there earlier will be given for the NEET exam. So NEET, I think you have sufficient time. Only thing is, once the time comes mentally or psychologically, you feel that it's quite far away. As you all know, in medicine, that's how it looks like. It looks distant. But even if you study the whole day, if you study entire month, you feel you just covered about 20% of your subject. So it is imperative that you're persistent, you are focused, you are aggressive in your preparation, and you don't allow any kind of compromise, because you worked so hard. Only thing now you have to start. I think a few people did take a good amount of break in between, but I think really now is the time. So I think the iniCT is going to get you in the mood first of all, and I think after that you just need to continue in the same mood towards the NEET exam. So that is the main advice that I can give you. So please suggest drugs and doses for migraine. See, as far as migraine is concerned, if the patient is mild, then still NSAIDs are the first line. The moment the patient start developing severe, then you have to go in for triptans. For acute patients, all triptan. So as far as prophylaxis is concerned, there's a big list that is there for migraine, of which generally we start with beta blockers first, and if they are not working, then we try the other drugs. But the most important drugs that are effective study-wise in prevention of migraine are beta blockers, then followed by tricyclic antidepressants. Then you have the valproate and topiramate. So these 4 drugs are efficacy-wise very, very high. Okay, then you have the other drugs. Now there are many drugs. You are going to choose the drug based on what other patient is suffering from, what other problem patient is suffering from. You got a patient who's got hypertensive, then you use candesartan, that will take care of migraine also, that will that will help in migraine prophylaxis also, that will help in hypertension also. Or you can use beta blocker. If a post-MI patient is there, then use beta blocker. That will take care of the migraine also, that will take care of the ischemic heart disease also. If the patient has got anxiety disorder, many of these females will have panic disorders or anxiety disorders, generalized anxiety disorder with migraine. Then you give a combination. If the patient has got a sleep problem, they're not getting good sleep, and they also have migraine. So if they don't have sleep and they have migraine, then generally tricyclic antidepressants are supposed to be quite good. We use it at bedtime. That induces some amount of sleepiness also. They sleep as well, get some sleep, as well as migraine prophylaxis also is done. So the choice of drug really in medicine is not just about the disease, it's what else the patient has got. So the combination of problems the patient has got, we address them together and then we treat. Remember that the botulinum toxin that has been approved in the treatment is only approved for chronic migraine. It is not for episodic migraine. Only chronic migraine botulinum toxin is allowed. Third, the monoclonal antibodies that are coming, they're all injectables as of now. So generally injectables to give, and we can use once a month injectables are there. Okay, so these monoclonal antibodies that are there, they are against in migraine. The efficacy is no doubt good, but the whole idea is that migraine is a lifestyle disorder. It's a psychosocial problem. It's a psychosomatic problem rather. So healthy lifestyle, those things are more important rather than taking care by drugs of the headache. It's more important exercise, good diet, proper sleep. Those things are more beneficial overall than just trying to hit migraine with a particular drug. So generally, the monoclonal antibodies that came out initially, we came with a lot of enthusiasm, but the overall thing now, these drugs are not that great. Okay, they are the CGRP and monoclonal antibodies I'm talking about. Which is most common in rheumatic fever, polyarthritis or carditis? Arthritis, one of the peculiarities of rheumatic fever is that whenever arthritis is severe, carditis is very mild. Whenever carditis is severe, arthritis is very mild. Some people have more carditis, some people have more arthritis. Overall, arthritis and arthralgia, I think arthralgia, if you say, is much more common. Is it wise to read USMLE first aid now? See, for the iniCT, if you have read it earlier, you can revise it. Okay, the USMLE Step 1 First Aid is an amazing book. Any exam, you can walk in it and you can expect at least, that book will help you get at least 10-15 questions correct. Okay, that's a really very good book. Okay, USMLE Step 1 First Aid. And it's a theory book, not an MCQ book. The authors' names are Vikas Bhushan and Towley. However, if you have not read it, and for 10 days before an exam where only revision is your only thing you should do for iniCT, for example, only revision now, you can't do anything new, then now reading it doesn't make sense. If you read it before, revise it. That too, revise select topics, like for example, biochemistry, some select topics in ANAT, patho, those things you can revise, or maybe pharmac. Rest, the ethics, the psychiatry part of it and all, you can skip. As far as the NEET is concerned, I was telling you, definitely you have time now. If you have not read USMLE Step 1 First Aid, this is a good idea to read it, especially because we're expecting MLE kind of, some kind of modification in the exam that might be MLE linked. If they are picking up questions from MLE, the USMLE Step 1 First Aid theory book, it's a theory book, it will be very, very useful because it covers multiple questions. That book is pretty good for first year, second year subjects. So Step 1 First Aid means you have ANAT, biochem, physio, patho, micropharmac, that part covered. I really like the book and I would definitely recommend it to anybody who is willing to read it. Okay, what is the indication for intubation on saturation level? See, the indication for intubation purely based on saturation is not there. If the patient is on NIV already, I think if you're talking about COVID, patient is already on NIV, then we are looking at other features. How much is the requirement of oxygen to maintain the saturation? Also, you need to understand one simple idea that patients on COVID, generally those who end up on, mechanically intubated on ventilator, overall the prognosis in such patients is not that great. So although it's not that you keep on denying intubation when required, you do give it. But we look at multiple things. We look at, is the patient using accessory muscles? Is the patient getting fatigued with NIV? Is the patient requiring very high amount of oxygen to maintain saturation? So those are all the other things that we are going to look at. And we also look at the PF ratio. So this is the PaO2 FiO2 ratio. The PF ratio, once it starts coming below 150, that is more important than just saturation. The PF ratio, the PaO2 FiO2 ratio below 150, plus accessory muscle usage, plus the patient getting fatigued, plus the patient not maintaining saturation on NIV. As you know, high flow nasal cannula in between had become very popular, but now because it drains too much oxygen, and in a condition where we have oxygen shortage, it's suddenly not becoming that good. In the sense, people are not very comfortable using it now because already oxygen shortage is there. So we are back again to NIV rather than high flow nasal cannula. But the thing is, when you have a PF ratio less than 150, when the patient has got accessory muscles used, when the patient's BP and heart rate are significantly getting affected, all these, when the patient has got respiratory rate going above 35, these are clear indications. Then you say, okay, this patient might need intubation. You need to intubate and you put the patient on ventilator. Any important points for Mucor? Mucor, as I told you, mainly it's a hyperferritinemia. That is the main trigger. Apart from that, it is uncontrolled glucose. So it's not just diabetic, non-diabetic patients also. Now you're supposed to keep the glucose under tight control to prevent Mucor. Third is Mucor. COVID is a thromboinflammatory condition that is purely vascular, in the sense it causes vasculopathy. It blocks up the small vessels, decreasing perfusion. And just like diabetes, because it's a vascular disease and it causes these microinfarcts, those in addition to the combination of high ferritin, to uncontrolled high glucose, all these might be associated with causing Mucor. In general, UK study, NICE guidelines, Indian guidelines, AIIMS guidelines, Ministry of Health, Family Welfare, whatever guidelines they're putting up, one thing is clear. The typical practice that we're doing of using very high dose steroids is not approved by anybody. The recommended doses are 6 mg dexamethasone or equivalent doses of prednisolone, methylprednisolone. Some people are using 20 mg dexamethasone or equivalent prednisolone. That is not recommended anywhere. No guideline is there connected to it. So AIIMS is very clear on this, that if you go above the recommended guidelines of 6 mg dexamethasone per day, then you are going to increase the risk of hyperglycemia. You are going to increase the risk of immune suppression, so much so that the patient can develop fungal infections like mucormycosis. So if a patient is worsening on steroid, then you need to understand increasing the dose of steroid is not given in any guideline. Okay, in MCQs you follow guidelines. It's not given in any guidelines. So you have to use other things. You can use other treatments like tocilizumab. I told you is one of the indications, is when patient is deteriorating, is not yet on ventilator, is on an IV still, and the patient's having a CRP that is going on rising, are all clues to tell you that this is a patient. And if you can do serial interleukin 6, fine. But as I said, measuring interleukin 6 is a big headache. It should be measured in a proper way. It should not be, the tube should not be shaken. If the patient is collecting the thing and going through some motorbike or car or something to get that tested, any shaking increases interleukin 6 level. So there are a lot of headaches of measuring interleukin 6 level. So this is the reason why CRP generally the thing that people follow even in the studies. So anyway, the point is, don't go for increasing high steroids, definitely not in MCQs at least. Okay, what is the recommended dose? 6 milligram per day. That's a low dose. Equivalent dose of other steroids you can use. You're not allowed to go higher doses than that, even if the patient is worsening. And that is at least as far as what the AIIMS guidelines are, and that is what as far as the some people are using pulse methylprednisolone, very large doses. That guidelines are not recommending. Epilepsy treatment, when and how to stop guidelines. See, as far as guidelines are concerned, no, they always choose the safe path. And guidelines are recommending 5 years from the last episode of seizure. If the patient has got 5 years, if the patient is in some profession that is that could be life threatening to others also, to the person also, like the person is a driver, the person is working in something that is allowing others and himself to be at high risk, then they are saying continue even more longer. So that means the duration will be more than 5 years also. So in general, for MCQs, it's 5 years. Last seizure, the patient should have got last episode of seizure. After that, 5 years. Now, what we follow is about 3 years, but generally that is not what is there in the international guidelines. Most of the standard guidelines are 5 years. Start and stop movements and maintain each movement which has more control, cerebellum or basal ganglia. Okay, so initiation and stopping movements, the main thing is basal ganglia. What cerebellum does is mainly it's a comparator. Comparator means it compares the intended movement to the actual movement. Cerebellum is aware of the initial limb position and what is the desired movement, how fast and how smoothly it has to be done, that computation and calculation, whatever movement has been initiated, one copy of the movement goes to cerebellum, and it's also picking up the information from the deep tendon organs, from the spinal tendons. It's basically picking up constant information from the limbs. So all this, the cerebellum is a comparator. It compares the intended movement to actual movement and gives some adjustment to make the movement smooth. That is the job of the cerebellum. But initiation and stopping movement to a large extent is done by basal ganglia. Okay, there's a reason why patients with Parkinson's disease, you will see, compared to cerebellar disease, are got more difficulty in initiating a movement, and when they are supposed to stop, they got more difficulty in stopping. We do something called applause sign in basal ganglia disorder. What is applause sign? The patient has to clap 1, 2, 3 and stop. But many patients with Parkinson's disease or patients who have got basal ganglia disease will keep on clapping more than 3 times and they are not able to stop. So this is known as applause sign. So like that, we do many signs to get this idea that there's a patient who's got a basal ganglia problem. Why Mucor is seen only in India in COVID positive cases? Because India, the mutant strain that is there in India, I really believe that is the core reason. Now that that strain is spreading in other countries, we might hear in other countries also. Okay, we might hear of it in the other countries also. So I really, there are other hypotheses. Some people are talking about industrial oxygen. Some people are talking about too much zinc. And in India, they prescribe things like anything like crazy. I told people, the moment they get COVID positive, there's no rationale of giving such high zinc, such high doses, of drugs like, and also don't forget drugs like favipiravir and all, which studies have not shown much benefit. People are using it very large doses, and it's supposed to cause high uric acid, high GI problems, and so many other issues. Even AIIMS guidelines don't support use of favipiravir, but many people are using it. So, I think all these might be contributory to some extent, and unnecessarily too much antibiotic. We don't follow guidelines. I think that's what happens. So people follow too much of their own stuff. I think that could be one of the reasons. But I really believe it is mainly the mutant strain that we are seeing in India. And it is aggressive. It is causing hyperglycemia significantly. It is associated with hyperferritinemia. Inflammation is more, so ferritin levels are increasing. And it is causing vascular occlusion because of the thromboinflammation. And that all put together is, I think, one of the reasons why we are seeing more Mucor here. So I really believe it is the COVID rather than any other factor. Important single inflammatory marker in prognosis in COVID, the answer is CRP. Okay, the single most important thing that will tell you about the prognosis to a large extent is C-reactive protein. After that, I would say look at D-dimer, but I think CRP is the main thing. How to differentiate between Valence syndrome and arrhythmogenic right ventricular dysplasia in ECG? See, Valence syndrome is basically a patient who comes with chest pain. Very classical list will be there. Patient has got chest pain, comes to the emergency, or because he's got such severe chest pain that is classically cardiac in nature, but by the time you do the ECG and all that, the patient starts feeling better. Many such patients are generally discharged home thinking that the patient has shown improvement. The patient himself will be keep demanding, I am feeling better now, the pain has come down, let me go home. ECG typically shows biphasic T waves. If the ECG shows biphasic T waves, particularly in the anterior chest leads, okay, you will see the ECG showing the biphasic T waves. So biphasic T waves you are getting, there are different types of valence in that. Also you have valence type A, valence type B. There's something called pseudovalence. Pseudovalence is when you have the QRS complex very tall, then pseudovalence. This valence does not have any significance. So the electrical voltages in the chest leads, anterior chest leads, that is V2 to V5. If the QRS complex are very tall or very deep, you cannot look at the biphasic T wave. It does not have any value. That is known as pseudovalence. So valence history is very classical. Arrhythmogenic right ventricular dysplasia typically comes with again chest leads might show, but it comes with no chest pain as such. That the patient comes more with arrhythmias. These arrhythmias that are there are transient. The patient can have a BT. The patient can have any other arrhythmia. Although we call it as arrhythmogenic right ventricular dysplasia, but you should know now that even left ventricle has got a disease process. It is autosomal dominant inheritance, so family history will be very strong in ARVD. Some family member, sibling, brother, father, uncle, somebody would have died prematurely with some sudden onset death. Unexplained death in a family member who were not sick, who did not have a chronic disease. Suddenly they died, they slept in the night, didn't get up in the morning or something like that. Those are also clues to suggest you the answer is ARVD. So valence is totally different. It's a patient who got chest pain, who's got a critical LAD stenosis. The LAD started allowing some blood to flow. Because of that, the patient started getting relief. Pain is becoming lesser. The patient has got anterior chest lead showing biphasic T waves. That's a classical description. If you get those things, then you're talking about valence. If you see in patients with arrhythmogenic right ventricular, what you see is epsilon wave, which is not really biphasic. You get more of double peaked T wave. Or rather after the J point, you're getting the double peaked wave, which is classical of what is known as epsilon wave. So epsilon wave and T wave problems are totally different. ECG wise also you can easily differentiate. Friedreich's ataxia comes predominantly more with sensory than cerebellar. Okay, Friedreich's affects all tracts, almost all the thick myelinated tracts are affected. So you see patient is going to have corticospinal tract findings. The patient is going to have posterior column findings. The patient is also going to have cerebellar tracts affected. Cerebellar findings also will occur. Not only that, on top of that, the patient can have even some amount of polyneuropathy. Neuropathy also will occur. So a combination of findings, particularly Friedreich's, the most important thing is posterior columns dominate. They are going to have severe sensory ataxia. That is one of the hallmark findings of what you see in patients with Friedreich's. Okay, also, anticipation will occur. It's a GA repeat amplification. So those things are also there. So family history amplification in the anticipation in the children, the posterior columns predominantly involved, corticospinal tracts involved, combination, multiple tracts are involved in patients with Friedreich's ataxia. So that's one of the basic differences between cerebellar diseases. Cerebellar, spinocerebellar ataxias also can have posterior column, but it is X-linked pattern. So the patterns are very clear for Friedreich's. What do you mean by how long COVID and what is its management? Okay, what do you mean by long COVID is? See, long COVID is patients who have got chronic manifestations after they recover from COVID. Most of these patients are not very sick to get hospitalized, did not need to get ICU or ventilator support, develop some mild cough, they recovered. But these patients never completely recover. They continue to have at the end of 3 months. 3-month period is important to use the term long COVID. After 3 months, their patient has still symptoms which are not completely gone. They're totally not normal after getting COVID. Now, this patient after COVID, this long COVID I'm talking about, the most common finding that they have come across is fatigue. Second most common is myalgia, and third is brain fog. Some kind of confusion. Patient does not have the interest to go back to active work the way they were earlier pre-COVID. The patient continues to have some kind of fatigue. They feel uneasy. They have sleep disturbances. So these are some common things. Although patient can have chronic cough, the patient can have low-grade fever. Some patients can have throat pains. So these are also things that have been described. But the top 3 or 4 are fatigue, myalgia, brain fog. Okay, these 3 are most important. So this is what you mainly see in long COVID. Now, long COVID, there is a controversy. Should we give some treatment? It's mainly supportive treatment. It is basically lifestyle. Now, there is some controversy about can we give a trial of steroids? The answer is no guidelines are recommending it, and it is not approved anywhere. So the main thing is supportive care. That's all. Okay, just symptomatic supportive care. Trace albuminuria is in post-COVID patient. Bipedal pitting and pain, UTI resolved. Please guide. Okay, see, trace amount of albuminuria, as long as albumin creat ratio is less than 300, then nothing much to be done. Can patients with COVID have glomerulopathy? Yeah, focal segmental glomerulopathy. That pattern has been described in patients with COVID patients. So some amount of nephropathy, some amount of albuminuria is fine. But you're talking about a patient having pitting edema. A trace albumin and pitting edema doesn't make sense. UTI is there, that's resolved. So please guide me what, if the patient has UTI, it most likely is secondary bacterial infection, possibly due to immune dysfunction that occurs due to COVID. So a lot of patients do pick up secondary infections post-COVID. The commonest is generally throat, because throat inflammation would have occurred. That's where the virus replicated a lot. So many people who recover from COVID, you'll see a lot of them telling about throat problems. And actually, we do recommend throat swab and culture. Culture and sensitivity is the best guide for us to decide what antibiotic. Using antibiotic without proper culture, without doing gram stain, without looking at the complete blood count picture, generally is irrational and it's not appreciated. So even in urine, same thing, get a urine gram stain, get a urine culture. If secondary bacterial infection, you can treat. If it's just inflammation secondary to the virus, then obviously you just have to wait it out. How to attempt for iniCT? I think Dr. Rajat and me have done a video of how to look at individual pattern of questions. You will see multiple choice questions. You will see, and I think Dr. Rajat and me just before last AIIMS have done a very nice video. I would strongly advise you to see that video. What we have told in that is how to approach different patterns of questions. Okay, single response question, how to attempt. In a patient who's in a question that has got multiple responses, like A, B, C is correct, A, D is correct. There are some techniques I've discussed in that I think might be very useful for you. Please do look at that video. Also, I have got an old video, I think that is there on YouTube, about how to approach AIIMS. Okay, the new pattern in AIIMS, I think it is. So that video also there. I would suggest please do look at it. That should help you in answering questions in AIIMS, the new pattern questions in AIIMS. In general, when you have 200 questions, the single best response are your best chance of getting reasonably good attempts. So out of 150 questions, at least see if you can do 145 attempts. That would be good. The remaining 50 questions, that might be new pattern questions. The sequential response questions are the most trickiest ones, which have got high negative marking. And the match the following ones. Those two, I would say you got to be a little cautious. Rest, otherwise, I think you can easily eliminate the options and you can answer. So I don't think the other pattern questions you might have so much problem. It's just these two, sequential and match the following, that you have to be cautious about. In general, unless you have attempts, remember you can't get a rank. It's a very highly competitive environment. You have to get a score first of all to reach in that rank zone. So if you are in the borderline, it will not help in any way. So either you have to get it, and if you have to get it, you need to get a good amount of attempt. So definitely the new pattern questions, some of them might be tricky. So your thing, you should carefully see how much to attempt. But the old pattern questions that are there, I think out of 150, 140 to 145, around 145 would be a good number of attempt for the out of 150 questions. The new pattern questions, you might have to leave more, particularly because some of them have got high negative marking, like sequential arrangement, that you have to see how many you can attempt. If you're really sure, you can attempt those also. What is duration of antiplatelets in post-MI? It depends. In post-MI, if you're putting a drug-eluting stent, the patient should be given 1 year of dual antiplatelet therapy. In a post-MI patient who's got a non-drug, bare metal stent, in a bare metal stent, you're going to give 3 months of antiplatelet drugs. In a patient with dual antiplatelet, a patient with drug-eluting stent has been put, then 1 year dual antiplatelet therapy is recommended. Okay, if the patient has got not myocardial infarction, is not acute coronary episode, but let's say the patient has got stable angina, or the patient had unstable angina, stable angina more importantly, and after that some procedure has been done. So sometimes stable angina patients also, angio is done, stent is put. Those patients, the recommended time for putting antiplatelet drugs is 6 months. Now this is as far as antiplatelet, particularly dual antiplatelet therapy I'm talking about. Patient acute MI had drug-eluting stent, because almost everybody gets drug-eluting stent. 1 year the patient took 2 antiplatelet drug. After that, lifelong the patient should be on single antiplatelet drug. Okay, so it is for life. After the patient finished that 1 year, 2 antiplatelet drug for 1 year. After that, 1 antiplatelet drug for life. In third year, please help me with a plan how to prepare for next exam. See, as far as third year is concerned, most important, whichever year you are in, focus on the exam that you have currently. For example, if you are having if you have ENT ophthalm PSM, that should be your priority first. It should have been read so well that you should have made notes, you should have done MCQs, you should attend the classes. Although you can attend a class of all the faculties if you have joined some coaching institute, attend all the classes. But the priority should be given to the subjects that you have, because the idea is not only should you get distinction for those subjects that year, but it should be prepared for entrance also. So first idea is that some people try to do too much in too little time. I don't think that would be advisable. Again, somebody is asking, how about reading Harrison? Rather than reading Harrison, I would recommend you try to finish off your first year, second year subjects. So if you are in your third year, until third year, first finish your third year subjects, then finish your basic sciences. Okay, so once your basic sciences are done, that means first year, second year subjects are done, and your third year subjects you are doing well anyway, then overall you'll be geared nicely to go for final year. Remember, those people whose pathophysio is strong. In my teaching career, I've seen some people whom I used to call above ranks. There are some people I used to look at them and I used to say, rank is nothing in front of them. These people are above ranks. Okay, for them, I used to, all our teaching careers, we used to see people first rank. But then after that, we realized there are some people who are above ranks. I remember one guy, his name was Vineet, I think in Lucknow, undergraduate. And by lunch break, when I spoke to him, I realized that guy is amazing. I mean, he was outstanding. And by next 2 days of classes, I realized what his strength was. He was too strong in pathology and physiology. That's why his very way of thinking and questioning was why it is occurring like this, rather than memorizing stuff. So we expected he'll do well. And I think I remember Vineet got second rank. First exam he wrote was during internship. He was not eligible for AIIMS. He got second rank in the All India exam. And then the first AIIMS exam after that he got first. He wrote JIPMER, I think he got first. PGI he got first. I don't remember him getting third rank. But we predicted this earlier. I remember taking a class in Mumbai and I saw one student who was, I think, really outstanding. And he was better than most of the MD people I was teaching in that year. He was an undergraduate. And I really think his strength was, again, pathophysio. So those people who shine, who are outstanding, who don't need to revise, again and again, they come out of the loop of forgetting, revising. They're totally out of that, is because everything is conceptual. They understand why, and that to get that base, you need to have good pathophysio. So do get your basic sciences, organized. Those of you undergraduates, particularly pathology, Robbins, is the heart of all the MBBS curriculum. The more you read it, the more stronger you are in, the more you can connect it with patho, with surgery, patho with medicine, patho with other subjects, the more stronger your overall build-up of concepts is going to be. So you'll be able to handle everything, regardless of what exam you're facing. You can handle it with a lot of confidence. So for third year, my advice is focus on your subjects and try to do the basic sciences. These are in priority. After that, if you have time, start looking at final year subjects. If a patient has 16/25 score on CT, does he need to get a CT scan done after getting COVID negative? See, as far as CT scan is concerned, the only place where they are recommending repeating testing or repeating CT is if the patient has got a sudden change. Like if a patient was having, a score, moderate COVID, he was on treatment, suddenly he deteriorated, suddenly saturation dropped. Remember I showed you that question? In that patient, the next step should not be add this drug, increase the dose of steroid. Those will never be the answer. The next step is get your investigation done again. Does the patient have some complication? Does he develop some, pneumothorax? Does he have some other issue? Is he picked up a secondary bacterial infection? And to some extent, radiological imaging will show us that. So that's when you need to get a CT repeated. In general, just doing sequential CTs is not going to help modify your treatment. Every time you get an investigation, the first question is, if I get an investigation and if I find this or that in the test, will it modify my treatment? If I'm not going to modify my treatment, just getting the investigation and knowing about it is of no use. If patient is already on, the drugs that are recommended, he's already on steroids, he's already on anticoagulants, he's already getting the treatment, then you should have a plan. If I get this and if it's showing this, then I'm prepared to do this. If there's no plan, you're not planning to do any change in the treatment, then don't get the investigation. So CT, don't forget, can be having radiation exposure that might be quite high. So no need to. And many people who go for CT pick up secondary infections and come. So there's all reasons why generally it's discouraged to do multiple, investigations unless there is really a plan for it. If a patient is on regular painkillers for his ortho problem, after how many days he and she can continue the first dose of vaccine? See, painkillers and vaccine, I don't think there is any connection. Nothing at least has been published in the Covishield or in the Covaxin guidelines. So I don't see any reason why you should hesitate. Only problem is if people are on immune suppressant drugs or they are on something that is suppressing immune system, the whole purpose of giving a vaccine is to activate the immune system, to prime it up so that the cell-mediated immunity and the humoral immunity both start getting activated. If you have immune suppressing drugs, then that will not allow the vaccine to have its efficacy. It will not have it, it will not have a chance to do what it's supposed to do. So those are the things that I think are not generally recommended along with a vaccine. But other than that, I don't see any reason why any painkillers or anything connected with vaccine giving. Polymorphic VT in shock, defibrillation or cardioversion. Any patient who's got a systolic BP less than 80 and the patient is in shock, regardless of what the arrhythmia is, next step will always be shock. It should be shock. Again, shock, two types are there. One is cardioversion, the other is defibrillation. If the patient has a pulse, then and the patient relatively is more stable, then you're going to go for cardioversion. Only two conditions you answer defibrillation: pulseless VT and ventricular fibrillation. Pulseless VT and ventricular fibrillation, the answer is go for defibrillation. This non-synchronized shock, defibrillation. If you have a patient who's got a pulse, you can feel it, it is there because VT generally is very regular. So that kind of a VT, although patient BP might be low, the answer is cardioversion. Or all other arrhythmias when you shock, atrial fibrillation, ventricular rate is very high, patient is unstable, because of that you need to shock, the shock is cardioversion. So only two places defibrillation is the answer: pulseless VT, ventricular fibrillation, baki sab cardioversion. And the rule is any arrhythmia, if the patient is got hypotension, means the systolic is less than 80, the answer is shock. Lung compliance graph. That's a physiology question. I think you should ask the physiology teacher. Okay, occipital headache typically is more psychological, stress-induced generally. So tension type headache, stress-induced headache, it fits more in that category. However, I would recommend you do take a good neurologist opinion. There are some neurologists in Bangalore, for example. We know there are some people who specialize in just headaches. In Mumbai also we know somebody like that. So there are places where you do have people who are just focusing on headache, as their main thing. And sometimes headache can be a big headache to manage. It's not as that easy as we think. There's a separate department in NIMHANS, for example, under Dr. Kulkarni, who is managing the headache. So headache is we have headache clinics, we have headache departments, monitoring and management, separate teams are there. So you have to really identify what the cause for the headache is and then decide what the treatment is. Does taking diclofenac increase chance of bleeding manifestation with Covishield? Not that I have read of anywhere. Okay, we've never come across that anti-inflammatory drugs are associated with bleeding or something. However, there are some people who take Covishield. They don't understand the concept that it is heparin-induced thrombocytosis, like thrombocytopenia kind of picture. And many people who are taking Covishield start taking antiplatelet drugs. Now, these are people who understand the concept of thrombosis, but they don't understand the pathophysio. The pathophysio is what? Okay, the vaccine-associated thrombosis with thrombocytopenia, pathophysio is like heparin-induced thrombocytopenia, where patient has got PF4 antibodies, and these patients platelets are dropping. And what are we giving? Antiplatelet drugs. Now, one doctor who talked to me, and he told me, sir, I am taking antiplatelets after Covishield, not because I'm worried about vaccine-associated thrombocytosis, thrombocytopenia, because this, even in Caucasian countries, where white population, they are saying this 7 per 10 million. Okay, so the frequency of the occurrence of this complication is very, very rare. Looking at these numbers, what they are publishing is very, very rare, right? So it's not 7 per 100, it's not 7 per 1000, it's not 7 per lakh, it's 7 per 10 million. That's the published data. So for this reason, this is not something that they are worried about. What they might be worried about is if I already have an atherosclerotic plaque And if I'm exposing some inflammatory response in my body, I might as well take antiplatelet. If myocardial plaque rupture happens, then at least it will protect against ischemic heart disease. So that was his logic. That makes sense. But for vaccine-associated thrombosis with thrombocytopenia, taking antiplatelet drug is just, they don't have idea what's going on. This is not platelet-induced thrombosis that is occurring. Rather, it's coming with thrombocytopenia. It is antibodies that are activated by the vaccine, and these antibodies are just like what you get in heparin. And the pathophysiology is totally different here. I mean, it makes no sense taking antiplatelet drugs if you're thinking about thrombosis because of the vaccine. I really don't see the logic behind taking. If you're preventing inflammation, or rather inflammation associated with ischemic heart disease, if you're worried about that, that makes sense. But not this. For this reason, taking antiplatelet doesn't make sense. Pulseless VT, monomorphic or polymorphic? It can be both. Polymorphic VT also can be pulseless. Monomorphic VT also can be pulseless. If VT rate is very, very high, then the heart will not get time to throw a good amount of volume, so pulse will not be felt. So pulseless VT can be both polymorphic as well as monomorphic. Either way, pulseless VT, the answer is defibrillatory shock. Please explain CRP and vaccination correlation. See, there are some people who put forward this idea, and this is all WhatsApp. Remember, the level of evidence that we have are, you have randomized controlled trials, meta-analysis, randomized controlled trials, we have cohort studies, we have case control studies, then you have expert opinion by people who are working in that departments in those respective specialties, and least is WhatsApp. Okay, WhatsApp, whatever information is coming, that should come lowest down as far as evidence is concerned. Now, we do see some people putting forward the WhatsApp that CRP, you have to check before getting your vaccine done. Now the concept here is key, those people who have got high CRP, as such, it's an inflammation in the body. Now you are giving a spike protein that might induce more inflammation, and the inflammation goes very high. I told you one of the consequences is, particularly what we have read about it, is key inflammatory processes as such who already have atherosclerotic plaque, it can trigger rupture, means it can precipitate an ischemic event. Now, point is key, any inflammation in the body can do it. Don't forget. See, the thing is now, in India, almost every place COVID is there now. It's not about you will not get it. It's about you will get it. When will you get it? So I've seen many people call up and ask me, can I avoid the vaccine? Why should I get myself exposed to some risk? The answer is simple. You will likely get COVID. Chances are very high. Question is when. It's not about will you get it. You will. Okay, possibility is very high. You will get it. When is the only thing that is there in your hand. So better to take the vaccine, because the risk that is there with either the vaccine associated thrombosis, thrombocytopenia, risk is 7 per 10 million, very, very less. And ischemic events, out of so many crores, I think they have documented some 40-50 people who developed ischemic heart disease. But don't forget, had they got the COVID virus, then also inflammation will be much more than vaccine. And definitely, again, that same thing, they would have precipitated ischemic heart disease. So the advice is simple. I think vaccine is the only solution that we have now. It doesn't matter whether you're going to go for one or the other vaccine, but taking a vaccine is something that you have to recommend. There are lots of conspiracy theories floating around, unfortunately, which are making the job more difficult. And I think it's important that wherever we can explain, we need to go ahead and try to explain to people that definitely vaccination is the way out. Okay, differences between SUNCT and cluster. See, SUNCT is short-lasting unilateral neuralgiform headache with conjunctival tearing, right? That is the full abbreviation for SUNCT. And cluster headache. One basic difference is between the two. Cluster headache typically is more longer duration. It takes about 20 minutes to half an hour to 1 hour. SUNCT is lasting for seconds. It will come flash of headache, sharp piercing type of headache. Last for a few seconds, go away. It will come and it will go away. It can be few seconds to about 120, 130 seconds. And it is multiple episodes. Typically, the episodes in a day are about 100, 200 episodes. In cluster headache, normally you get episodes of around 5 to 7 to 8, 10, something like that. Okay, 5, 10, you can count it. But SUNCT, the episodes are uncountable. That many episodes the patient might have in a single day. Cluster headache is got a peculiar thing that it starts every day on the same time. It is going to occur for a few days. Again, for months it might not occur, and again it will occur. Cluster headache will respond to triptans. SUNCT, not much benefit of giving triptans. You can try IV lidocaine, you can try anticonvulsants. That's why it's called neuralgia form headache. So treatment also is very different between SUNCT and cluster. Anyway, the clue in MCQ is, if the headache is lasting for 20-30 minutes each episode and multiple episodes in a single day, that's cluster. It is sharp, both will have autonomic manifestations. They are trigeminal cephalalgias, both of them. So retroorbital or periorbital severe pain, tearing of the eye, nasal congestion, unilateral are clues that will be there for both between SUNCT and cluster. Big difference is SUNCT is multiple episodes, short lasting sometimes for seconds, whereas cluster is much more longer duration. That's the most important difference that we look at. What about antibody dependent enhancement is total crap, and it has been discarded by most people. So who were that popular guy in Europe who's supposed to have said it? CMC Vellore has got a very nice video about this. I think the title is, this is a very good microbiologist in CMC who's come up with this video. I mean, myths with COVID or something like that. So please check that out. It clearly mentions what all people are telling about the vaccine and why they are wrong. And I think that was really very enlightening. Why XDescend is prominent in cardiac tamponade? So in XDescend, basically, as you know, it occurs when ventricle contracts. When ventricle contracts, it pulls the atrial wall down. Whatever we are studying in the JVP are basically right atrial pressures. You need to understand it's not ventricular pressure, it's not left atrium, it's right atrial pressure. Imagine you're sitting in the right atrium. In a patient who's got cardiac tamponade, as the ventricle, just before the patient goes into ventricular systole, what would have happened is ventricular diastole. Diastole, the heart fills. In diastole, the heart fills, ventricles fill. When the ventricles fill, the right atrium, being the thinnest wall, gets compressed from outside because of pericardial fluid. Let me repeat it. Diastole is the time when Y descent occurs. Systole is the time when X descent occurs. During diastole, ventricle got filled. Atria got compressed. Atria is under high pressure. Now ventricular systole started. In ventricle systole started, when the ventricle contracts, then outside pericardial pressure will decrease. Right? When the ventricles start going inside, obviously they're pushing the blood out of the heart into the major vessels. As the ventricles squeeze in, outside pressure will drop. The drop in outside pressure will relax the atria suddenly. The sudden relaxation of atria during ventricular systole is the XDescend. As you all know, XDescend typically coincides with ventricular systole. That's why you get a rapid XDescend in patients with cardiac tamponade. How to identify whether P or T wave after QRS in rhythm strip? How to identify P or T wave? One simple way we look at it is the frequency, the sharpness of the wave that you get. Is P wave typically is more high frequency, means you get more pointed. T wave, on the other hand, is more low frequency. It's more low frequency. Each point, if you look at it, is more curved. It doesn't have that sharp frequency that P wave has got. So one is the P wave frequency. That's how pointed it is. That will help us. Secondly, we look at lead 1 and look at lead AVF. Generally, if it's originating from the SA node, the P wave, then the P wave has to be upright in lead 1 and lead AVF, suggesting that it's starting from the right atrium and is going in the direction of lead 1, is going in the direction of AVF. So if that is the case, then it's very easy to differentiate P wave from a T wave, unless you have an ectopic atrial activity, which is a wandering pacemaker, or the patient has got multifocal atrial tachycardia. Then also you can appreciate. But if the entire ECG will be so obvious, then you will know that this is nothing but a multifocal atrial tachycardia, because you will see three different types of P waves. If that's not there, the P is coming from SA node. The P will always be upright in these certain leads in which the current is flowing towards the leads. So based on that also you can tell whether it's a P wave or a T wave. And generally V1 is one of the best leads. Lead V1 is a very good lead to look at P waves. And if you have a confusion, that lead generally sorts it out. Which is better, Covaxin or Covishield? See, Covaxin does not have any published data, so unless we have a data that is peer-reviewed, nobody can say. In Covishield, they are talking about vaccine-associated thrombocytopenia. No documentation, anything like that with Covaxin. So you might say that wise, safety-wise, it might be better. There are some recent rumors, not studies, which are suggesting that inactivation process of Covaxin is doubtful. It might reactivate back and get a, you can get the virus. All rumors, no data, nothing published. As of now, what it looks like to me is whatever vaccine is available, you need to take it. NDTV today, I saw an article suggesting that after the first dose, and this is not a published data, this is news, I have to verify it because today only I saw it. We have to check the actual, study. That news was showing that Covishield has got more antibodies after first dose than Covaxin. But they were quoting a study, and I didn't get time to look at the study today. But definitely I'll go through that study. If that's the case, then I think Covishield might be better if it's got more antibody production compared to Covaxin. But I think the idea is get whichever is accessible, whichever is there, get it. Okay, so just not getting a vaccine is the most stupidest thing. Getting a vaccine, whichever is there, and getting it done fast, because COVID will come. It's not a matter of will it come or not, it's a matter of when. So it's better to get the vaccines. Barter Syndrome and prostaglandin association. See, Barter Syndrome basically is a defect in the channels in the thick ascending loop of Henle, and the main issue that is happening in these patients is that there is high renin, there is high aldosterone, but the patient has got sodium loss, the patient has got polyuria, the patient has got hypokalemia. So the place where they're supposed to act, the aldosterone, that is, that doesn't work. So the overall, thing about Barters in detail with the concepts and the thing, I've already explained in my video. I would recommend you to definitely take a look at it. The point is I'm looking for the PowerPoint to show you the image, and I wanted to show you that particular image which will give you the concept. The idea is ki, the junction of the thick ascending loop of Henle or the DCT and the afferent arteriole is where the juxtaglomerular apparatus is present. That's one of the places that produces prostaglandins. If the feedback doesn't come, because even the feedback that comes, whatever sodium should come in the thick ascending loop of Henle, that juxtaglomerular apparatus has a sensor that senses sodium. Based on that, it adjusts the lumen of the afferent arteriole. So it doesn't get the feedback, it produces more prostaglandins. And that is the problem that is there. So one of the drugs that we use in patients with Barters is we block the prostaglandins by using drugs like indomethacin. By allowing indomethacin, by giving, blocking the prostaglandins, we allow the afferent, dilatation that is there, because prostaglandins keep the afferent arteriole dilated, not constricted, dilated. We cause some amount of constriction that helps in preserving sodium and helps in decreasing the polyuria. So patients with Barters will come with polyuria. They do come with sodium loss. Both are because of more volume that is getting filtered in the glomeruli, because afferent arteriole is dilated. What we are trying to do is constrict the afferent arteriole to some extent, preventing that excess filtration and excess polyuria that is occurring. So this is general concept that is there. So what are the things? Two things. One is there's a problem in the sensing of sodium at the level of juxtaglomerular apparatus. Second problem is the sodium potassium 2 chloride channels. There's a defect in the thick ascending loop of Henle. Barters, 5 types of Barters are there. Each type of Barter I've explained in my video. Please look at it. But general idea is, because feedback doesn't come, prostaglandins are high. What do prostaglandins do? They dilate the afferent arteriole. If the afferent arteriole is dilated, what happens? More volume is filtered, more sodium is lost in the kidney. What do? We constrict the afferent arteriole, and we use drugs like NSAIDs, indomethacin and all that. This helps in preventing further polyuria and decreases the amount of sodium loss. So I think any precautions we can take to prevent Covishield-induced thrombosis. See, I can only say based on what they are suggesting, 7 per 10 million. And if you are living in a city like say Bangalore or Delhi, if 10 million vehicles are moving around, about 7 will definitely meet with an accident. The risk of getting this problem is kind of less than what you would get if you travel a day in a city like Delhi or Bangalore and don't meet an accident. The risk is almost similar. I would say don't think too much about this. And definitely taking antiplatelet, some people are doing it. It may protect against the immune-induced, ischemic events and all that, but does not do anything to the vaccine-associated thrombosis with thrombocytopenia. Only thing is between 4th day to 20th day, that too only after first dose. It doesn't occur after second dose. 4th day to 28th day, keep a watch. Any kind of symptoms with this, if you get a drop in platelet count, if the patient has got some thrombogenic features, if the patient has increasing D-dimer, if you have any of those features, then you need to take the treatment. The treatment is generally very good, and it is immunoglobulins and steroids, and they work. The risk of developing this is, as I told you, almost negligible. It's not 7 per 100, it's not 7%, it's not 7 per 1,000, it's not 7 per lakh, it is 7 per 10 million. So it's pretty rare occurrence. So don't worry about it. So drug of choice for steroid resistant nephrotic syndrome, the answer is different in adult and children. The more effective drug is supposed to be cyclophosphamide, but because of the side effects, we tend to avoid it, particularly in pediatric age group. We go for levimizole. It's supposed to have lesser side effect, but it doesn't work in everybody. So because we try first levimizole, slightly less side effects, it works in not 100%, it works in most of them. And in adults, at least they can bear the side effects, but in children, definitely levimizole should be answer, pediatric age group. In adults also, the other drugs, alternative drugs are generally preferred, but if they ask you in exam which is most effective drug, efficacy wise, cyclophosphamide is superior. Okay, generally what is tried in children, the answer should be levimizole. In general pediatric guidelines, you will see levimizole mentioned. In adult, you will generally see cyclophosphamide in many of the guidelines. What do you think about third wave? I don't think about third wave. I have no idea. I really believe a significant percentage of us already got COVID, and those who didn't would have got vaccinated. I'm hoping it will not occur, but that's just a hope. Sensible thing is what people are talking about. They need to prepare for it. And I think that's all we can do. We need to prepare for a potential third wave, and let's hope it will never occur. So this is it. I think I've covered most of your questions. I love the interaction with all of you. I hope all of you found this discussion beneficial. My best wishes to all of you. Take care of your health. Actually, even I was down with COVID for quite some time in between, and but fortunately, I did come out of it. Do take care of your health and do get vaccinated as early as possible. And as far as AIIMS iniCT is concerned, make sure that you are focusing on your class notes for the main branch of revision, and whatever additional stuff that you do is definitely going to be beneficial. Do questions every day, a fixed period. Try to do questions so that you know the hang of questions just before you go for the exam. If you don't do questions and if you're doing only theory, then you'll not know how to tackle questions in the exam. You'll not know what common mistakes you're making. So these are some basic things. I think it's too less a time for me to give you any specific plan for iniCT. All you can do is just revise and go for the exam with your thing, because most of you have read well, and the discussion that we do in our institute is generally concept based, so you'll have definitely a big advantage. So I'm hoping many of you will do very well. My best wishes to all of you. As far as NEET is concerned, you have time on your hand, and don't allow it to slip through your fingers and regret later. You have good amount of time, and good means you have sufficient time to do good revisions. So do take this opportunity seriously and do work on it. It is going to give you results that you'll be very satisfied for the rest of your life. So do utilize this time carefully. So my best wishes to all of you. Good luck and thank you so much. Okay, somebody's asking, should they take heparin or low molecular heparin following Covishield? The answer is definitely no. No heparin, no low molecular heparin following Covishield, because we are talking about a condition that is similar to heparin-induced thrombocytopenia, where similarly, just like heparin, you get antibodies which are platelet factor 4 antibodies. So definitely, please don't give heparin or low molecular heparin to anybody post Covishield, because of this risk might actually magnify. Okay, so not indicated. And no guidelines as of now what you need to take after Covishield to protect against this risk, because this is almost negligible. As I told you, this is there more for the Caucasian white population. In India, the risk might be even lesser. Okay, thank you so much.